Hello, thank you very much for the opportunity to present at this conference today. My name is John Brayley, Chief Psychiatrist here in South Australia. The topic that I'm presenting on is psychosocial disability support and reducing the mortality of people who receive that support. Before I begin, I would like to acknowledge this land that we meet on today is the traditional lands for the Kaurna people, and that we respect their spiritual relationship with their country. We also acknowledge the Kaurna people as the custodians of the Adelaide region, and that their cultural and heritage beliefs are still as important to the living Kaurna people today. As this is a national conference, I also wish to acknowledge traditional owners around the country. This is the context of today's presentation. Three particular areas of work that have occurred in our office. The first is the SA Mental Health Services Plan. This is work that we did in collaboration with the SA Mental Health Commission. It has three broad goals: personalisation of care, integration, and safety and quality. As part of improving safety and quality, there is a Towards Zero Suicide initiative. These initiatives that focus on engagement and follow-up with people, when you look at evidence internationally and nationally, can lead to significant reductions in mortality for people who use services, 20%, 30%, in some cases higher than that, over 50%. So these are strategies that we're thinking about and implementing for our services, and are applicable across clinical services and non-government services. Suicide prevention, another area of work with the Office of the Premier's Advocate on Suicide Prevention, Wellbeing SA. There's been work in developing a suicide prevention bill, which is currently in consultation on the Your Say website here in South Australia. This bill focuses on a cross-government action. Suicide prevention can't reside only in health. And then there's the work on the NDIS Psychosocial Disability Transition Task Force. This task force has been looking at transitions, partnerships. It has people from state departments, services, Commonwealth departments, NDIA, NGOs, consumers and carers, statutory bodies, are all sitting around discussing the risks of transition and how they might be managed. These areas of work provide background to some of the thoughts in this presentation today. Because I am going to be talking about suicide prevention, some of the themes can be distressing, and if that's the case, it's important that people speak to somebody, to a support person, and if needed, call a support line such as Lifeline. To start with, I'd like to spend some time looking at this slide. This slide is part of an AIHW publication from September 2020. It describes the leading causes of death for people with disability. You can see on the left, primary disability type, and then on the top, it's ranked 1, 2, 3, 4, and 5. Of course, many people can have dual disabilities, and it's common for mental health problems to coexist with other disabilities. At the bottom, you can see for people with psychosocial disability in this group, and this is a group of NDA recipients. Suicide is the leading cause of death, followed by accidental poisoning, coronary heart disease. There are suicide prevention opportunities here, as well as opportunities to improve physical health and address premature mortality. We'll look at physical health first. This is a slide taken from information from the Commonwealth's Equally Well initiative about the health of people with mental illness. 4 out of every 5 people have coexisting physical illness. People are vulnerable because of their physical ill health. This is also particularly relevant at this time of the COVID pandemic. But you can see the list there: cardiovascular disease, respiratory disease, metabolic syndrome. I'm sure people are very familiar with those concerns. And from the same publication, people are 6 times more likely to die from cardiovascular disease, likely to die between 14 and 23 years earlier than the general population. This slide from Equally Well describes the influences on mental health and physical well-being, and a number of those influences, most of them actually extend beyond healthcare and can be the focus of rehabilitation, disability support, so that lifestyle factors are addressed, and through the services that will help people, support people, help people work towards their goals, physical health can also improve and people can live a longer life. If we move to suicide prevention, this slide is the suicide data for Australia. So 2% of people die by suicide, and concerningly, you can see the increases here for all people, for males and females in suicide rates. Because of COVID, we are receiving more information about suicide than we have in the past. We're in the process of setting up a suicide register in South Australia. They already exist in other states such as Victoria and Queensland. Other states are working to have them. But as we've looked at our data, we can see that significant numbers of people who die by suicide have had contact with mental health services. And this is also an international observation. Approximately 30% are either in contact or have had contact within the previous 6 months. If you increase that to people who have ever had contact, according to our data, just over a 6-month period of looking at loss of life by suicide, it goes up to 47%. This doesn't include people who may also be seeing private practitioners. It indicates that for clinical services, there are significant opportunities to intervene. It goes back to the discussion about towards zero suicide initiatives. But the same applies for non-government services, because non-government services will have the engagement, the contact, working with people to their goals, delivering hope. And it's interesting, of course, that many of our non-government providers, for example, for the NDIS, are also suicide prevention providers in areas such as aftercare. So in many respects, disability support and rehabilitation can also be suicide prevention activities. It's for these reasons that people need to be trained. Now, this is a slide from the UK. It's a slide that belongs to Joe Rafferty from Merseycare, but it just illustrates the level of training in his organisation. Everyone in Merseycare gets trained. We've heard recently that NDIA staff will be trained in suicide prevention. I think you could make the case that every disability support worker should have training in suicide prevention. And as you can see in this slide, there's different levels. It might be tailored towards different responses and engaging people with care, but it becomes like a universal competency. As part of Towards Zero Suicide initiatives, toolkits have been developed, and this is equally applicable in non-government support services and disability support. The leadership in terms of reducing suicide, training a confident and caring workforce, identifying risk. Now that might be different levels depending on whether you're a support worker or a clinician, but identification, the fundamental issue of engagement, engagement with people as part of caring for people, and a suicide care management plan. It may be that a safety plan may have been developed in a clinical service, but other providers in collaboration will need to be involved in implementing it. This treatment transition is very critical, the transition between services, and quality improvement. And part of that can be analysing incidents. You know, how can we improve if an incident has occurred, if there has been an attempt or there has been a loss of life, using every opportunity to help, to learn from that, to help others in the future. So in conclusion, I think I've endeavoured to bring together in today's presentation some different streams of thought. I'm sure for most people listening, there are things that they would be already thinking about, but I hopefully it's been useful to highlight the importance of a holistic recovery-based approach, the potential benefit for suicide prevention training for all staff, not just government staff, but provider staff as well, collaborative care between disability support staff and clinical staff to implement safety plans, and ultimately safety plans belong to the person anyway, so assistance might be needed, and quality improvement strategies such as collaborative incident review and learning lessons for the future. Thank you very much for the opportunity to present to the conference today. Thank you.